look at it, this was the phase 2b, phase 3 study, which looked at nanomicellar cyclosporin, which came by the term of OTX 101, 0.09%, vis-a-vis vehicle, vis-a-vis 0.05%, because they wanted to look at which concentration is better, 0.05% or 0.09%, and the treatment duration was 12 weeks. And it was found that the one which had nanomicellar cyclosporin 0.09% had faster action, which was 2 weeks as opposed to the vehicle. So that is why it is more efficacious as compared to 0.05% nanomicellar as well as 0.05%, which is commercially available. Now, this was another study which was again randomized controlled trial in more than 700 patients, which looked at the one which was proven, that means nanomicellar 0.09%, vis-a-vis vehicle, to look at the safety, and this was again done for 12 weeks, and at all points in time it was found that the nanomicellar cyclosporin had improved the total corneal staining much more as compared to the vehicle. And I think corneal staining is very important, because corneal staining means that the patient is having symptoms and is also having signs. Then this was again for the global symptom score, or what we called as SANDE. That is how we analyze the symptoms of the patient. And again, both the treatment groups, they demonstrated 30% mean decrease from baseline in modified SANDE scores, and there was no difference in the treatment effect which was observed. And of course, artificial tears were not allowed in this study. Now, again in visual acuity, again the same data, it was found that the nanomicellar cyclosporin patients did better, and there was also at 3 months 65% of the central corneas were completely clear, with 56.9% in cases of nanomicellar versus 38.3% otherwise, and the same results were also replicated at 3 months follow-up. Now, this is the real world treatment in patients with dry eye disease. How did they arrive at it? They went to all the insurance companies. In India, this treatment is not covered by insurance, or these drugs may not be covered. But this was a study which was in US, where drugs are covered by insurance, and they wanted to know how many patients were on cyclosporin 0.9, 0.05 or liftigrest. What was the discontinuation time to treatment and discontinuation of these? And it was again found that the patients who were in the group of nanomicellar cyclosporin, the mean treatment duration was 11.6 months, vis-a-vis 8 months for liftigrest, vis-a-vis almost 7.9 months for the commercially available cyclosporin. So the discontinuation rate with the nanomicellar cyclosporin is also less. Now, this again looked at the instillation site pain to stop the dry eye disease, and more than 95% of the patients experienced either no or mild instillation of the site pain with the nanomicellar cyclosporin, which is actually being marketed as Cequa from the Sun Pharma Pharmaceuticals. This was for the safety, whether there were any ocular adverse events or not. And again, the issues were only two. That was pain at the site of instillation and conjunctival hyperemia. Blurred vision was present in less than 1% of the cases. And of course, cyclosporin A, 0.09% of the Cequa did not report any taste alterations, which is there with the liftigrest. So, what were the conclusions of the studies which were done with cyclosporin 0.09%? The conclusions were that from day one, no or mild instillation of site pain for more than 95% of patients. After just 14 days, it starts to act, in the sense that it improves corneal staining. So its duration of action is only 2 weeks. At month 1, patients had reduction in total corneal staining and also symptoms which improved. Visual acuity also improved. Almost 2/3 of the patient were had clear corneas and tear production, which nearly doubled. And at 1 year, more patients were still using this drug as compared to liftigrest and the commercially available cyclosporin 0.05%. And of course, the most common adverse events reported were pain and conjunctival hyperemia in these patients. So thank you very much for your kind attention. And if there are any questions, we can
Thank you,
take up the
ma'am, for that
questions.
enlightening talk. So this is your chance to catch hold of Dr. Amrita, ma'am. So she has vast experience in treating ocular surface disease, and she is an authority in any cornea topic or ocular surface for that matter. So this is a time for audience interaction. Um, any of your doubts can be cleared.
So I have a
Dr.
doubt. I
Vichi.
think let's clear that also. Where is Sanvarma? So what about the economics of Sequa vis-a-vis Restasis? Because I think people don't want to use Restasis because it is very expensive. I hope your drug is cheaper than Restasis.
Can the lights be on? The hall lights.
The cost of actually cyclosporine being marketed by Allergan, that is costing 25.55 for a box of 30 unims. Vis-a-vis Sequa, which has 30 unims, is costing 1722 rupees to your patients. So this is a 0.25 ml vial, which has got enough drops. Even if the patient is wasting it to use the unim, still it has got enough number of drops to take care of the dosage part. Almost 850 rupees economical per box of 30 unims as compared to Allergan's product.
Okay, I have another question for you. You have a cycloimmune, which is 0.1%. So what do we do? Shall we tell all the patients stop this and start using Sequa?
So, ma'am, I have been only involved with promoting this product for last 16 years in my division only. So, this is one such product which will definitely, I would say, meets unmet needs as you were mentioning about it. I'm not saying anything is bad, but only thing is that something better comes up in the market. As Madam was pointing out, the product cyclosporin, which is currently available in emulsion form, it is hydrophobic in nature and it takes good 3 months to reach the required concentration in tissues of cornea conjunctiva. That is how the delayed response of current cyclosporin is there. Now, since it is encapsulated with the hydrophilic outer layer, the penetration is far more superior, and within 14 days, you will see. I was reading through one of the promotional article given by Allergan that the concentration of drug reaching cornea tissues, it is 1440 nanogram per gram in cornea with their product, which against with Sequa, it is 4800 nanogram per gram. So you can imagine the concentration of the drug reaching cornea tissue so quickly and giving faster relief to your patients. Costs sometimes become imperative, but at the end of the day, what happens is the longevity of treatment with the conventional cyclosporin and the one which is available, since it gives a quick response, I think your patient's religiousness to continue with the medication and see the results quickly will be one of the best thing to happen for your patients. Choice is all yours. It is
Thank
a platter
you.
which is
Thank you.
available. But then I believe that the current, whatever new things are happening, it is for the betterment of patient. And hopefully, I think patients are going to benefit a lot. It's been almost 6 months of promotion, but then we have received a tremendous response. Even Madam Namrata also, I think she will vouch for it. She had been using since the launch of this product. And Dr. Anil sir also, I think I came almost 3 months back and met him. He has been also using
No,
it.
no, we are still trying it, Deepak. We've not
No, no,
watching
I
for
am.
it, but because we have a whole gamut of drugs, our this thing, and I can discuss it with the other panelists also. Our dilemmas are quite a lot. One, that the patients who are already on restasis and are doing well will not change to Sequa because they are used to restasis and they can afford it. One is
I
this. Second is that, again, we know about restasis and we know about cyclosporin 0.05% that you can continue it for, say, at least 1 year. And if you want to stop, again, these are the things which we have to look even for the nanomicellar one. How long can you continue it? When should you stop? For what prolonged, how long do you, Dr. Anil, how long do you continue your cyclosporin for? I mean, we give it for say 1 year, and then when do you think you now need to stop it?
Yeah, it's difficult to say, ma'am. Like the Restasis, when they launched, they told that you can use it for 6 months to 1 year and try stopping it. But a lot of patients actually had recurrence of the symptoms once you stopped it. So a lot of them are on long-term therapy for for long periods.
Same for you, I think, Anita. Do you want?
Ma'am, I have not started using Sequa because the pharmacy where I was where I am working now
No, but
is not there. Is no-
cyclosporin in general.
Cyclosporin actually it is not a wonder drug, and it takes its own time to act. So 1 year is the minimum time I give, and if the patient is
Madhu,
about
what about you? Minimum is 1 year, maximum till the time the
I don't usually continue it on a long term. I use it for 3 months, ma'am. Give a break, use low dose steroids in between, and again start it.
Okay.
I don't.
So that is also a good model to, give breaks, to break that vicious cycle which we were talking about, and then to restart again.
Restart it, yeah.
I have patients who are almost on 5 years of cyclosporin, but the problem is the moment you withdraw, like Dr. Anil was saying, they are not happy with it and they want to, come back to it again. So I think with your product, these are the type of questions we will need to answer, which we've not answered with the existing products. And if that, is taken care of, then possibly. Of course, one big advantage is that it starts to act in less than 2 weeks, which is good. Because then you don't have to put the patients on topical steroids for a prolonged period of time, which is 6 weeks.
Yeah,
So
that
you are
is-
shortening the topical steroid period by about 4 weeks.
The other indication where we started using it is in the post-refractives, high myopes, who are usually steroid responders. We are tapering them to loteprednol low strength along with this, and then slowly we are stopping loteprednol also and continuing on cyclispf, especially post-PRK.
Okay, yeah.
Post PRK patients.
Post-PRK, high powers. High myopes usually become steroid responders.
Anybody has any question? Yes.
Good afternoon, ma'am. Ma'am, you have 5 layers of cornea. We already know that. There's something called Deuce layer, sixth layer. What is its composition? What's its main function?
Sixth layer of cornea. Is there any postgraduate here? That comes as a short note. The sixth of the layer of the cornea is Dua's layer, which
Dua's
is
layer, Dua's
Dua's layer, which is present just above the Descemet's membrane, and it's about 10 microns in thickness. And it's actually, I think, it's nothing but the condensation of collagen which is present right above the Descemet's membrane.
So it is having collagen, not cells. It's having
No,
collagen.
no. It is having collagen. Anyone can frame a better answer than what I have framed. I'm sure Madhu can. Madhu. Any other question that anybody would want to ask?
Now, can I make a comment, ma'am?
Yes.
See, this regarding other aqueous-based cyclosporin preparations, I don't know, I have my reservations about it. I've used multiple products and I have not seen the same response with the emulsion form, either Ristasis or the Sequa product. So it is, I think, other one is much inferior, definitely.
Which one is inferior?
The aqueous-based
Aqueous
ones.
based is much inferior.
Compares, like we have a lot of products which are available which are aqueous based, which makes sense also because it is basically cyclosporin is lipid soluble. It does not penetrate the
Yeah.
cornea just like that.
I think you need to study comparing the two of them. Only thing is the sample size is going to be really huge. Because you are comparing the same kind of product. And to be able to show a difference, you need in both the arms very huge number of cases.
Ma'am,
Like I said, we would need to